Eosinophils are granulocytes originating principally from the bone marrow. They were first described in 1879. Their normal count is 0 to 5% or 0 to 0.04 times 10 to the power of 3 per microliter. Eosinophils are 12 to 15 micrometers in diameter, with a half-life of about 18 hours in circulation. The eosinophil originates from IL-5 responsive CD34 plus myeloid progenitor cells. Cytokines like GM-CSF, IL-3, and IL-5 influence their proliferation and differentiation. IL-5 is primarily released by activated Th lymphocytes and in small amounts by other cells. Eosinophilia is an increase in circulating eosinophils greater than 0.4 times 10 to the power of 9 per liter. It is classified into mild, moderate, and marked types based on the count. This video will now review the causes of eosinophilia. Non-clonal or reactive eosinophilia appears to be induced by cytokines from T lymphocytes. It is associated with various conditions, including tissue-invasive parasites and allergic conditions affecting the respiratory tract, gastrointestinal system, skin, and connective tissues. Tissue invasion by parasites causes a distinct eosinophilia. Eosinophils adhere to larvae coated with IgG and IgE. Intracellular granules are expelled to attack and destroy the larva wall, as the larvae are too large for phagocytosis. Allergic disorders often show a moderate increase in eosinophils. Eosinophilia also accompanies the pulmonary infiltrate with eosinophilia, or PIE syndrome, which involves asthma and pulmonary infiltrating eosinophils. Clonal or neoplastic eosinophilia is characterized by persistent eosinophilia greater than 1.5 times 10 to the power of 9 per liter, along with tissue infiltration. This can be a clonal myeloid or lymphoid neoplastic disorder, often involving mutations in growth factor receptor genes. Idiopathic eosinophilia, also known as idiopathic hypereosinophilic syndrome, is diagnosed when the cause is unknown and clonality cannot be demonstrated. This chronic persistent eosinophilia can lead to extensive tissue damage, particularly to the heart, due to granule release. It is important to differentiate idiopathic hypereosinophilic syndrome from reactive and clonal eosinophilias. Eosinophilic leukemia typically presents with myeloblasts, whereas idiopathic hypereosinophilic syndrome and reactive eosinophilia present with mature eosinophils. Eosinopenia, a decrease in eosinophils, is difficult to determine and may be seen in acute infections, inflammatory reactions, and with glucocorticosteroid administration. Basophils are granulocytes arising from CD34 plus myeloid progenitors in the bone marrow. IL-3 is the main cytokine for their growth and differentiation. They constitute less than 1% of total white blood cells and are 10 to 15 micrometers in size, with dark blue or blackish granules. Both basophils and mast cells are crucial in inflammatory and immediate allergic reactions, as they release inflammatory mediators. Basophilia is an increase in basophils greater than 0.2 times 10 to the power of 9 per liter. It is linked to immediate hypersensitivity reactions and chronic myeloproliferative disorders. Absolute basophilia can help distinguish chronic myeloid leukemia from a leukemoid reaction. This scene continues the topic of basophilia. A decrease in basophils is difficult to establish, but is observed in inflammatory states and following immunologic reactions. Mastocytosis involves a fourfold increase in mast cells in affected tissues, most commonly the skin. No clinical disorder involving a decrease in mast cells has been identified.